Welcome to this explainer. Today, we are going to break down a really complex, endlessly fascinating, and, frankly, sometimes alarming chain reaction known as nephrotic syndrome. Inside your kidneys, right at this very moment, millions of microscopic filters are working absolutely tirelessly to keep your blood clean and perfectly balanced. But what happens when that biological security system gets sabotaged? Well, we're going to explore exactly how a tiny microscopic injury can cascade into massive body-wide consequences. And more importantly, we'll look at how medical science steps in to stop it.
It is truly incredible how dependent our entire physical structure is on things we literally cannot even see with the naked eye. So, in a healthy kidney, you have these structures called glomeruli, and they act as highly selective filters. They let the waste and the extra fluid pass right into your urine, but they tightly hold on to your vital proteins. When those filters suddenly break down, it triggers this massive domino effect that radically alters the body's chemistry.
Here is our roadmap for today. We're going to cover the broken filter, the causes and risks, the warning signs, how it's diagnosed, comprehensive care, and we'll wrap up with some real patient cases. Let's get right into it.
Let's start with the big picture and establish exactly what we are dealing with. Section 1. The kidney's broken filter.
What's really fascinating here is that nephrotic syndrome isn't actually a single isolated disease, not at all. Instead, it's a specific group of clinical signs, a syndrome, that points to a completely broken biological security system. When the glomeruli are damaged, they just start leaking massive amounts of protein, and this results in 4 classic hallmarks: excessive protein in the urine, dangerously low protein levels in the blood, widespread swelling, and highly elevated cholesterol.
To really put the sheer scale of this problem into perspective, let's look at this number. For an adult to actually meet the diagnostic threshold for nephrotic syndrome, they have to lose more than 3.5 grams of protein per day in their urine. Now, in a healthy person, that number should be practically zero. Zilch. So this is a massive biological leak. It's robbing the body of albumin, which is this absolutely crucial protein that acts kind of like a molecular sponge, keeping fluids safely tucked inside your blood vessels.
Okay, this 6-step domino effect shows exactly how the whole condition progresses. First, the glomeruli and their specialized cells, they're called podocytes. They sustain an injury. Second, the filtration barrier completely fails and large amounts of protein just leak out into the urine. Third, because of that leak, albumin levels in the blood absolutely plummet. Fourth, without that albumin to hold it in, fluid seeps right out of the blood vessels and into the body's tissues, which causes severe swelling or edema. Fifth, the liver starts panicking from the low protein. It acts like a stressed-out factory manager going into overdrive, pumping out excess cholesterol in this desperate attempt to fix the blood chemistry. And finally, step 6, because vital proteins that prevent clotting and fight off disease are also being lost in the urine, the patient's risk for life-threatening blood clots and severe infections sharply spikes.
So the crucial question is figuring out what actually triggers this microscopic sabotage in the first place, right? Let's move to Section 2, Causes and Risk Factors.
Doctors basically approach this syndrome through a great divide: primary versus secondary causes. Primary nephrotic syndrome simply means the disease originates directly within the kidney's own structures. The kidney itself is the main target. Secondary nephrotic syndrome, on the other hand, means the kidney is just collateral damage from a broader systemic condition that's happening elsewhere in the body. Things like diabetes mellitus, lupus, and viral infections like hepatitis or HIV, all of those can cause secondary nephrotic syndrome. Taking a closer look at those primary causes, we can see a really distinct difference in how this syndrome targets different age groups. Minimal change disease, or MCD, is by far the most common primary cause in kids. Interestingly, if you look under a standard microscope, the kidneys of these children look almost completely normal, hence the name minimal change. But in adults, the primary causes are usually much more structurally damaging. Specifically, we're talking about focal segmental glomerulosclerosis, which creates actual scar tissue in the kidney, and membranous nephropathy.
Now let's zoom back out to the macro level and see what the patient is actually experiencing day to day. Section 3, Symptoms and Warning Signs.
Patients often report profound fatigue, loss of appetite, and some really significant weight gain just due to all that fluid retention. But one of the most surprising early warning signs is highly foamy urine. You might be wondering about this classic symptom. Why does it happen? Well, it happens because that massive amount of leaked protein physically alters the surface tension of the urine. When it hits the toilet water, it acts exactly like soap, whipping up a thick layer of foam.
As the fluid leaks into the tissues, patients will commonly experience swelling around their eyes, especially first thing in the morning, followed by swollen ankles and legs as gravity pulls that fluid down throughout the day. But beyond the swelling, there are critical emergency warning signs we have to talk about. Severe shortness of breath or chest pain, that could indicate a pulmonary embolism. Sudden, painful leg swelling is a major red flag for deep vein thrombosis, a blood clot in the leg. Remember step 6 of our domino effect? The loss of anti-clotting proteins makes these patients highly vulnerable. Any of these signs means the patient needs immediate medical attention. No waiting around.
To confirm these symptoms and rule out other causes, doctors essentially have to play detective and measure the exact extent of the chemical imbalance. Let's look at diagnosis and potential complications.
Getting a diagnosis requires a real multi-tool approach. A simple urinalysis combined with a 24-hour urine collection confirms that massive proteinuria we talked about earlier. Blood tests will reveal the classic low albumin and the high cholesterol levels. A kidney ultrasound helps doctors visualize the size and shape of the kidneys. But here's where it gets highly specific. An actual kidney biopsy is frequently needed, especially in adults. Doctors need that microscopic tissue sample to differentiate between diseases like FSGS or membranous nephropathy, simply because the specific microscopic damage completely dictates the exact treatment required.
So, once a precise diagnosis is made, how do we rebuild that biological filtration barrier and manage the systemic fallout? That brings us to Section 5, Comprehensive Treatment and Management.
Treatment is highly tailored. It is rarely just one magic pill. Instead, doctors utilize a cocktail of medications. Corticosteroids are the frontline defense, particularly for minimal change disease, to rapidly suppress the underlying inflammation. Medications like ACE inhibitors or ARBs, which are typically blood pressure drugs by the way, are used specifically because they decrease pressure inside the glomeruli, essentially patching the protein leak. Diuretics force the kidneys to excrete extra fluid, pulling that severe swelling out of the tissues. Statins bring the rampant cholesterol back under control, and anticoagulants are prescribed for high-risk patients to prevent those dangerous blood clots we warned about. For really tough cases, stronger immunosuppressants might even be needed.
But medicine isn't enough on its own. While the kidneys are healing, lifestyle and physiotherapy management are absolutely critical. Patients are placed on a moderate sodium restriction to stop fueling the fluid retention. And interestingly, patients shouldn't just overeat protein to replace what they are losing. A renal dietitian actually has to carefully control their protein intake to avoid overworking the damaged kidneys. Furthermore, combining targeted nutrition with specific low to moderate aerobic physiotherapy exercises is vital. Prolonged inactivity due to severe swelling can cause severe cardiovascular and muscle deconditioning, so guided progressive movement helps these patients maintain their strength safely. Let's ground all this clinical data by looking at how this actually plays out for real patients in the real world. Let's explore real cases and prognosis.
Consider this first case. A young child who wakes up with inexplicably puffy eyes and has that telltale foamy urine. The diagnosis? Minimal change disease. Now, for a child with MCD like this, the prognosis is often very good. They typically respond quite well and quite quickly to a targeted course of corticosteroids. The swelling goes down, the protein leak stops, and the child can usually return to a totally normal, active life, though doctors will definitely monitor them closely for any future relapses. Conversely, let's look at case 2. An adult with a long history of poorly controlled diabetes who develops severe leg swelling. This is secondary nephrotic syndrome, driven directly by diabetic damage to the kidneys. This requires a much more complex, long-term management strategy. The medical team has to aggressively control the patient's blood sugar and blood pressure, deploy diuretics for the swelling, and utilize ACE inhibitors to protect whatever kidney function is left. The main goal here is to prevent the steady progression into end-stage chronic kidney disease. Ultimately, what you should take away from this explainer is that yes, nephrotic syndrome represents a massive failure of a critical biological security system. The microscopic damage is profound, and the resulting chemical chaos in the body is incredibly serious. But with early detection, precise diagnostic detective work, and a comprehensive, customized treatment plan involving both medication and lifestyle management, swift intervention can absolutely restore a patient's quality of life. The key is catching those warning signs, like that foamy urine or unexplained swelling, and acting fast. It really makes you wonder, doesn't it? What other invisible battles are your microscopic filters fighting for you right now, completely unnoticed? Thank you for joining me for this explainer. Stay curious, and please, take care of your kidneys.